First of all, to infection COVID. I will start sharing the screen now. So as I was saying, I'm going to talk about COVID and pregnancy. And as I was saying, thank you for inviting me to talk about this topic that is many times forgettable. And let's go ahead. So I will be following this outline. First, I will discuss about. Second, I will talk about the effects of the infection on pregnancy. Third, I will be talking about vertical transmission, if it's possible or not, management protocol, and at the end I will discuss a bit about the more evidence that we need on pregnancy. And let me start with this acknowledgement that I will try to summarize the evidence that we have so far. But this evidence, I have to say that we will have more for longitudinal, consecutive, and more large cohorts that for sure will be coming soon. But as far as we can, I will try to summarize, as I was saying, with the evidence that we have. So let's start talking about the effects of pregnancy on the COVID infection. Why were we discussing that? So if we go to the evidence that we have from other infections, for example, flu and avian flu that we had pregnancy, mainly in late pregnancy, think that pregnancy is a period of the life that women are like overwhelmed with because they have to cope with them and with the baby and the placenta and everything. So these infections are known that are worse in late pregnancy. So we had first that impression that maybe this COVID infection would be also worse in pregnancy, especially in third case reports started to come from. I will summarize the evidence that it's mainly coming from care series, the largest this clinical spectrum seems to be similar to other women at similar age. That means that in most cases, the infection is mild. Only about 4% of cases will be severe, and the critical cases are very, very few, less than 1%, most likely. So it's very similar to the non-pregnant patients. So many of them have fever, cold, few of them have dyspnea. They are less common, and few of them will also have diarrhea. No reports on cutaneous or on skin lesions have been described. If we look at the lab of these patients, they usually have lymphocytopenia, increased CPR, and there are some lab things like transaminases or proteinuria that, as I will be discussing later, that have been in the literature that they could simulate a preeclampsia. So the labs look like a preeclampsia-like with the transaminases and proteinuria. As I was saying, very few cases will have severe pneumonia with positive CT, and the only thing is that from most case report, when they have pneumonia, severe pneumonia, most of them will be admitted with intensive care unit, not because of mechanical ventilation, because mechanical ventilation or the critical care, it's very few reported in the literature, but we guess that because of the concern of the pregnant women, if there is severe pneumonia, most of them will be admitted to intensive care. Other complications have been also described in pregnancy, like copulation disorders, renal failure, sepsis, and few case reports. The mortality seems very pregnant women, usually it's young, So the mortality is similar to non-pregnant women, very low. So as a summary, very few pregnant women with COVID infection will go to the intensive care unit. That's because most cases will be mild forms, and and of course we also think that there will be lots of asymptomatic undetected pregnant women. So really the clinical spectrum is very similar as in non-pregnant women at the same same age range. Remember that pregnant women is usually milder in women as compared to male, and we are talking about young women. That's the spectrum that we expected. So it's similar to non-pregnant patients. I wanted to highlight this data that was published from New York. That's the only really consecutive cohort up to date that they were just testing all pregnant women attending for delivery in this large maternity in New York. They are reporting 200 obstetrical patients going there. As you can see, many of them were negative, and from the positive patients, so they were doing CPR to all the pregnant women going to delivery, and most of them were symptomatic. So this confirms what I was saying, that the spectrum that are related to the case reports that we can infer from case report is really the peak of the iceberg, because most of the pregnant women will be asymptomatic. Let's go to the next step. That's the, again, we go to the same series of case reports, so we don't have a like longitudinal large course available. Let's hope that soon we'll have that data. But what information we know from this case series? So at the beginning, there was discussed if there could be a higher rate of miscarriage, but that was not confirmed. So it seems it is 0%. So we really don't know, but so far it doesn't seem that it increases a lot the miscarriage, as well as congenital malformations. There is very few information or no information about that, but there is not a big alarm or a lot of increase in congenital malformations detected in the maternities, but we will need long-term or long-term check all pregnant women, and we will need these larger studies. About perinatal death, there are some case reports on deaths supposedly related to COVID-19 infection, but the rate seems to be very low. And again, we don't have large consecutive series to really discuss that or to really know if it increases or not. So we need to wait. The reports on low birth weight or IUGR are not really conclusive. Again, it seems that it could be 33% of the infected patients, not that much. And as I was discussing previously, it has been reported that there could be a misleading diagnosis or some relationship with preeclampsia, because the lab tests are very similar in COVID-19 infected patients, and also there could be misleading diagnosis with preeclampsia, but there is also postulated that the COVID-19 infection, if severe, could affect the placenta and secondarily increase the rate of preeclampsia. There are some few reports or discussion in the literature, but let's see how it finally evolves that. So let's see if that's really that case. The rate of preterm delivery also varies a lot with the case reports. Some case reports say 6%, that would be like the normal in the population. Some of them 40%, seems extremely high. But I have to say that these case series reporting that high preterm delivery, it's mainly iatrogenic. That means that if a patient gets a COVID-19 infection at 30 weeks, and then they start getting, the women starts getting severe respiratory problems iatrogenically, and that's the most commonly reported cause of preterm delivery. So it doesn't seem that it increases the spontaneous preterm delivery, although we have to wait for large to really know that. And the rate of C-section, it seems also increased in COVID-19 infected pregnant women. And this large, the first series from China reported 90%, but this most likely are related because in China already the C-section rate is very, very high. And then also because at the beginning they didn't really knew what would be the effect of COVID-19 infection in pregnancy. There were fears that it most likely explains why these patients were mainly delivered by C-section, because now we know that vaginal delivery is allowed. Ideally, it's the ideal scenario, unless the patient really gets very, very sick. But so as I was saying, most likely the C-section very high rate reported. It's also iatrogenic reported because of fear of pain of doctors, or because the respiratory problems of women, and they ask this patient to just take the baby and then move the patient to the intensive care unit. So as a summary, it seems that mild forms of COVID-19 infection does not alter pregnancy, or at least the prenatal outcomes or the big obstetric symptoms most frequent. Severe forms that really the patient gets a lot of respiratory syndromes or hypoxemia that could increase the rates. We cannot really say that there is some impression of increased preeclampsia or diagnosis between COVID-19 and preeclampsia-like symptoms, and insists that we really need I wanted to finish this part, so just focusing also on two case reports. One of them was reporting a case of placental infection. It was a case report from 2 months ago. They were reporting that they were confirming that the virus was in the placenta infection. That was a case of miscarriage, late delivery with chorioamnionitis, that really the placenta seemed to be infected. But it's true that it's on the only case report really looking at the placenta and confirming the infection. So we know that the virus can go there, but it's most likely only in the very severe cases with the viremia very high, because I will be discussing later that the viremia, so the virus in the blood of these patients seems to be very low. So most patients with mild symptoms will not have the virus in the blood. So it's very unlikely that the placenta gets infected. And only in the very severe cases, it could be that the placenta gets infected. And also related to that, and what I was discussing with preeclampsia, there is a hypothesis that because this viral infection, it could give some coagulation problems or vascular malperfusion, clots in the placenta and the vessels, and that could increase potentially the risk of preeclampsia RVGR. So there are some cases report vascular malperfusion, residual arteriopathy, and problems with these placentas, and secondarily then go into more preeclampsia or UGR. But as I'm saying, these are just few case reports, and we will need to really wait for long series, well documented, to really see if that's just punctual cases, so just few cases related to very severe cases, or that's really the case with more common in COVID infection. Okay, let's move on and let's talk about vertical transmission. So in this, I will say vertical transmission, if exists. Before that, in this virus, we know that the virus is mainly respiratory, so it seems that when there is an infection, the virus is present in the respiratory system and the respiratory tract very commonly, but it's rarely found in blood. So in mild cases of COVID-19 infection, the rates of viremia are about 1%. So it's very rare that we could really find the virus in the blood. It's true that in very severe cases, when we look at adult cohorts, non-pregnant with very severe disease, the viremia can go up to 15%. So it could be that in more severe cases of pregnant women, the virus is circulating in the blood and it could go to the placenta and pass the fetus. At the beginning, there were no reports of infection. There were suspected, but some of these case reports are not clear if it's vertical transmission or horizontal transmission. I think that that's pretty difficult because the women gives birth and then the neonate goes with the mother breastfeeds, the mother touches the baby, the father touches the baby, most likely mother and father are infected. So the horizontal transmission is there. It's very difficult to differentiate what's vertical transmission or horizontal. Case reports later very well documented that seems that yes, that it's true that it could be some vertical transmission, but as I was saying, if it exists, seems very low because the viremia is very low. So considering pregnant women, we have to say to them that most likely, very likely, but very, very low rate of vertical transmission. And then if it occurs, it seems that in the neonate, the disease is very, very mild. So it's when counseling the pregnant women, we can be reassuring them that most likely everything will be fine. I wanted also to discuss a little bit about the management protocol of these patients. So it will depend on the severity. And let's remind again that most likely many patients will be asymptomatic with very few symptoms, very mild. And only a small proportion will be moderate or severe. So asymptomatic patients or mild patients, non-infected patients will be managed at home. So we just phone them to see how they are. They do more things. So I was saying, if they are mild, we'll just follow up them. And remember, in pregnancy, it's better to avoid ibuprofen or any non-steroidal anti-inflammatory drugs, not because of COVID, but because these drugs can close the ductus arteriosus of the fetus, so they are contraindicated late in pregnancy. So we will use paracetamol if they have fever, and that's it. And then the only main thing to remember with these mild cases of COVID infection in pregnancy is that pregnancy per se, and mainly in the postpartum, it's a risk factor for thrombotic disorders. And as we know also, COVID-19, it's potentially prothrombotic. So these patients, even if they have mild disease, they deliver. We will counsel them to give heparin to prevent the thrombosis, and mainly 10 days up to 10 days postpartum. So that would be like the only really treatment or preventive treatment that we will give these patients. If we move on to the moderate patients, the patients with really symptoms and more important clinic or more important symptoms, in these patients we can add medications. In our protocols, in our center at the beginning, we were giving hydroxychloroquine. Now we move on to lopinavir and ritonavir. And then in some cases, if there were more severe, we could, so as I was saying, with this lopinavir and ritonavir, we have experience with HIV patients, pregnant patients. We know that they are safe in pregnancy. And if needed, we could add other drugs like interferon or remdesivir. Interferon, there's some evidence, it seems that it's also safe in pregnancy. Remdesivir, we don't have we don't know the effect on pregnant women because there are no trials on them. There are some case reports that they have used in very severe pregnant women this drug, and it seems safe. And we can say that, and from other drugs from the same family, they seem relatively getting worse. We could use them in pregnancy. We could also use the prone position in these pregnant women because it has been reported in pregnancy to be safe. In this case, that the symptoms are moderate, so the disease is more severe than in the mild. We will remember also the heparin, it's very important, and we will keep the heparin in the postpartum, which is, as I was saying, the higher risk period, up to 4 to 6 weeks for postpartum. And then in the severe cases that will need critical support, we can do whatever is needed as in non-pregnant women. At this point, if really it's a critical case, that as I was saying, it will be very rare in pregnancy because they are young, usually healthy women. It's very rare that they need critical support, but if they need it, they can do whatever is necessary with mechanical ventilation or prone position and all the drugs I was discussing before. And if needed, again, to map, if needed, in these really, really critical care cases, there are some reports also suggesting that it could be used. And again, heparin, it's very important, so we will keep the heparin during the treatment and then follow up postpartum. Finally, I wanted also to discuss some other things, because in these pregnant women, it's not just that we treat the women, but we remember that these pregnant women will have a baby, and in many cases that we would like to manage them at home, like or just from time to time because they are mild, but many of them will need to go talk home to the hospital because they have a scan or because they have to deliver. It has been really a challenge in our service, in our department, to manage that, because we had so in other conditions, in non-pregnant patients, you can avoid hospital more easily. But in this case, if the patients need to deliver, they will need to come to the hospital. So we have the non-positive patients, or the patients that we don't know the status of COVID, that they need to come to the hospital, and maybe they have fear to come to the hospital because they have fear that they will get the infection in the hospital. And then we have these positive patients that we will need to manage. Ideally, the universal screening to all pregnant women attending to the hospital that will need to be attended to the hospital. The ideal scenario is to have universal screening and to do the screening with as fast as possible. And then if we admit a pregnant patient in the hospital, we know if it's positive or negative, so we can manage accordingly and follow the protocols. Then to reorganize all the service with one clean, non-infected group of patients, that of course we can allow the parents to be there, the partners to be there. Everything will be nicer, because delivery should be a nice period of your life that you have to be ideally with your partner, and then enjoy the birth of your child. So if that's in a clean environment, so a circuit that you know that it's fine, try to promote as natural as possible the deliver. And then in the patients that are positive, especially adequate to that, so all doctors, nurses, and midwives that will need to contact these patients are adequately with all the security that they need. And then also the challenge to keep the partner there, and then to, at least given the circumstance, that they could have contact with the child, with the newborn, and then let's try to do it vaginal delivery, and let's try to do our best. That has been a challenge for us. I think that now we have more data, and in most hospitals the protocols have improved and could offer like a better delivery for these patients, so they could at least try to feel it or to live it as the better as possible. Just to remember that vaginal delivery is allowed. That would be the ideal scenario in these patients infected. And then breastfeeding is recommended. It doesn't seem that the milk has the virus, so it doesn't seem that the virus goes to the milk, as I was saying, because most likely the viremia is very low, so it has been non-reported transmission through breast by the milk. It's different, the contact, but the milk. And then the benefits of breastfeeding are so high because of the many things, because the bonding of the mother, and then the health of the short-term health of the newborn and the long-term health of the child. The breastfeeding has so many benefits that all organizations and the World Health Organization has also supported the breastfeed. It's recommended in these patients. They just need to have some cautions. That means so wear a mask and clean often the hands and try to avoid other things. But the breast milk, it's very good for the child. So let's try to recommend that and help the mother to breastfeed. So then let me finish insisting on something that I have been saying throughout the presentation, that we really need more evidence on pregnancy. Mainly, let's summarize what the things that we already know from this case series, that is the evidence that we have. So symptomatic COVID-19 in pregnancy seems to be similar disease as compared to non-pregnant women at the same age. So mainly mild disease. It's true that it can increase the risk of thromboembolic disease, and remember that pregnancy and postpartum are high, also increase the risk of thromboembolic disease. So remember this thromboprophylaxis with heparin in these patients. The risk of prenatal complications, it seems mainly in the reports, mainly related to iatrogenic complications. That means C-section or preterm delivery because of iatrogenic indication. But it could be, we will need to wait for large cohort to know if really in severe cases, it could be that it's increased the prenatal complications. But it seems that it's mainly related to severe cases, not to mild or asymptomatic disease, which are the most common. And again, to remember that the risk of vertical transmission is really, really low. But okay, as I was saying, this data comes from case series reports, and these are the tip of the iceberg. These are the reports that come from patients that go to the hospital about all these asymptomatic patients. That seems to be the large population. So we estimate that we really reject very small proportion of the cases that are really there. So the proportion of cases that we detect are very, very low, most likely 1-2% of them. So really the clinical spectrum that I have been describing are the more severe cases, or the cases that are showing more symptoms. So again, insisting that we need large study population cohorts looking at constitutive pregnancies with universal screening. So we are working on that, and we hope that soon we will have data from our center, from Hospital Clínic in Jandarewa and Sant Pau. We are doing a multi-center study in Barcelona, and we hope that we will be able to provide more this type of data from a study population, just with universal screening to all pregnant women attended. And this will enable us to know really the clinical spectrum and the prenatal outcomes, if they are affected or not. So that was everything. Thank you for your attention, and looking forward that this pandemic will improve, and we will slowly come back. We'll be able to come back to normality, and more and more to that if there is more cases or the pandemic evolved, that we will know better how to fight against that, and how to reassure or to counsel our pregnant women that most of them have been very worried and with very stressed, with a lot of uncertainties. So really doing research on this area is really needed, and let's hope that we will get soon more based data that will enable us better counseling to our patients. Thank you very much. Ya está, gracias.